All right. Hi, everybody. It's 2:15, so we might as well get started. I'm Mike Bushy. I'm the from Indiana University and moderating this women's mental health oral presentation session. And I'll actually ask Chris Lano to come up and introduce our first speaker.
Thanks very much. So I'm really excited to present this first speaker because she is the winner of the DeLynn Fisher Clinical Research Award. So the DeLynn Fisher Clinical Research Award is presented for significant achievement in clinical research and the highest rated paper submitted to presentation at the annual meeting. The award is named after Ben DeLynn and Keith Fisher, who were two former kind of Academy presidents and who made a lot of contributions both to the field of CL psychiatry and to the Academy. This year, the DeLynn Fisher Clinical Research Award is being given to Dr. Nancy Byatt. Dr. Byatt is a perinatal psychiatrist and professor of psychiatry, obstetrics and gynecology, and population and quantitative health sciences at the University of Massachusetts Chan Medical School. Her work focuses on the design and implementation of interventions to improve parental and child mental health outcomes. She has received numerous federal grants, has published over 90 peer-reviewed articles, and has won several awards for her work. Additionally, she developed the Massachusetts Child Psychiatry Access Program for Moms and is the founding executive director of the Lifeline for Families Center and the Lifeline for Moms program at UMass Chan Medical School. So I'm very happy to present Dr. Byatt, who will be giving a presentation entitled "The Program in Support of Moms, Results of a Cluster Randomized Controlled Trial of 2 Active Interventions Addressing Perinatal Depression in Ambulatory Obstetric Settings." So Nancy, come on up. One more, sorry. Thank you. Okay, great.
Let's get my slides up here. Thank you, Chris. That was very nice. It was a very nice surprise to receive the DeLynn Fisher Award here. Let me turn this on. Can you hear me okay? It's going through. All right. I'm just going to go over here. I don't like podiums. So yeah, I'm going to present the results today of a study that we did called PRISM, which is Program in Support of Moms. It was a cluster randomized control trial, which looked at 2 perinatal depression interventions. These are my disclosures. So perinatal mood and anxiety disorders are recognized as a major public health problem. They're very common. They're undertreated. And they're now recently, based on the most recent data, are the leading cause of maternal death in the United States. 23% of deaths are due. So a lot of professional organizations are recommending screening and addressing this. However, the question is always like, how do we actually do this? And what do you do after a positive screen? So most of our research in our program has focused on building the capacity of obstetric settings to be able to increase access to and the quality of perinatal mental health care. And I'm going to present 2 interventions focused on that. In this study, what we did was we compared the effectiveness as 2 interventions, MCPAP for Moms, which stands for the Massachusetts Child Psychiatry Access Programs for Moms, and PRISM, Program in Support of Moms. So MCPAP for Moms is a statewide program. It really aims to build the capacity of OB settings to address perinatal depression and to increase access. And it has 3 core components. The first is education. So we have toolkits and trainings. We do ground round birthing hospitals. The second component is consultation. This is done by telephone or through a one-time face-to-face consult. And the third component is resource and referral. So linking patients with therapy in the community. And as I mentioned, this is a statewide program. So because any provider working with any pregnant or postpartum individual in Massachusetts can call our program and get consultation, they all have and we can all see them for one-time consult. It covers the whole state of Massachusetts. So I'm going to give a couple case examples about how MCPAP for Moms works. So, and this is a little bit different than collaborative care, and that the way that we believe the engine of this program or the mechanism by which it works is really telephone consultation. We actually have data on this that Grace here did as her dissertation, which is beyond the scope for today. But we have data that supports this being the mechanism. And so I'm going to give a case example. I cover the phones once a week for MCPAP for Moms. I was on call on Monday. Somebody called. They said, I have this patient. She's been on, bupropion in the past. She'd stopped at around 8 weeks gestational age. She said, I want to start Zoloft. And the patient was getting worse because she'd stopped bupropion. We talked about you want to use meds that have worked before. She decided that she should probably restart the bupropion, and that was the end of the call. That's an example. Another example, somebody called about a patient with a really complicated past psychiatric history. We could have talked for an hour, not that the OB would have tolerated that, but we wouldn't, neither of us would have felt comfortable with the OB managing that patient. So in that case, we do a one-time consult, and where one of our psychiatrists sees the patient and then refers, and then if needed, we can refer to psychiatry, and the OB manages until we can get them to longer term care, or the OB just manages after the one-time consult. The other thing we do, give another example, somebody called, they had a patient who had an EPDS of 10 and didn't have a psychiatric history. And so in that case, we did a referral to the community. One of our resource and referral specialists goes into our database, they look up resources, they call the patient, refer her to therapy in the community. And, you know, we're excited that the MCPAP for Moms in Massachusetts inspired federal legislation for other programs like it. And now there's 19 access programs across the United States, and they cover, they have the potential to cover half of the births. There's 3.6 million births. So we're excited about this model, that it's been scaled, and that, and the purple states are the ones that are aspiring. So there's a lot of states who are looking to get access programs funded. So we're excited about that. However, we also recognize that it's not a panacea. And you notice that I said it has the potential to cover all those births, because there's still challenges with reach, right? And so when we think about the perinatal depression care pathway, which really starts with, you know, detection of depression, then there's assessment, treatment, follow-up monitoring, ideally, you know, improved outcomes for families. And there's that relationship between the provider and the patient throughout this. When we think about MCPAP for Moms, it really focuses on these first few steps. So you heard the examples I gave. A provider calls our program, you know, we provide them consultation, they know how to start treatment, or we get them referred. What it doesn't do is really make sure, in the way that collaborative care does, to make sure they're doing measurement-based care and that they're really getting down the whole depression care pathway. So we developed PRISM really as a way to build on MCPAP for Moms to provide proactive practice-level implementation assistance to help practices really have depression be part of their workflow. So it's there just like diabetes. They've never screened a patient diabetes and be like, well, let me know if you need anything. They would follow up and make sure the blood sugar is under control. The goal is to do the same thing. And the way we do this is there's 3 phases to this process: planning, implementation, sustainment. And each of these is a step. So like steps 1 through 6, what we essentially do is we form a QI team. That's step 1. And then we do a baseline assessment. The QI team might be an OB, a champion, a practice manager. Then we do a baseline assessment and we look at all of the standards of care that ACOG recommends and so forth, and look at to what extent are they meeting those or not. We then present those results back to them, and we work with the practice to come up with goals. A goal might be we want to screen 100% of our patients 100% of the time for depression at 2 time points in pregnancy, once postpartum. And then what we do is we work with them to come up with a workflow that really looks at, you know, how do we accomplish these goals? So for example, who's handing out the screen, at what time point, at what visit, who's responding to the screen, what if the Selm-Harb question is positive, and when do they call MCPAP for Moms? And how can, you know, MCPAP for Moms be helpful? After we do that, we develop an implementation plan and a workflow, and then the practice starts implementing. We have a plan to communicate that to all the people in the practice. And then what we do is that's communicated to the practice, and then there's a training in depression for everyone in the practice. So then they implement, and then the last couple steps are sustainment. Then we continue to have meetings with them, and we go through the goals. All these goals are measurable goals, and they might do, for example, a spot check of the chart and look at, are we screening all the patients? If not, what's happening? And then we troubleshoot. And the goal really is that we're helping them implement step care. So for example, if it's mild depression, the OB would manage on their own. If it's more complicated, as you heard in that case, they might call us if they have a question. If it's more complicated than that and severe, then we might do a face-to-face consultation, or we may do that and refer, or both. And then one thing the study does is we had a navigator who would have a registry of patients with depression, similar to collaborative care, and the navigator would keep track of all the patients and call them at certain time points to check in with them about, did they get to their appointment? Are they taking their medicine? And really serving as a one to help them navigate that care pathway, and also to serve as a liaison between the provider and the patient, because the provider's never going to have time to call them and be doing that. So those are the 2 interventions, MCPAP for Moms in PRISM. And this was a cluster randomized controlled trial. So these are, as you heard, they're practice level interventions. And so we randomized by practice, and we had 5 practices that had MCPAP for Moms and 5 that had PRISM. And what we did was we recruited a little over 30 patients per practice, and it was an average of about 30 per practice, patients who scored over 10 or equal to 10 on the EPDS, and we followed them till a year postpartum. And we also looked at fidelity to the care pathway. So what we were interested in was looking at their treatment participation, depression outcomes. And the other thing we were looking at was to what extent are we helping the OB practice to actually do everything in the care pathway. What we hypothesized is that we would see a 2-point difference of differences in the depression score. So we hypothesized that with MCPAP for moms, you'd see an improvement in depression of 2 points. With PRISM, you'd see a greater improvement. So you'd see an improvement of 4 points, 2-point difference between the groups. So first, I'm going to talk about the fidelity of the care pathway. What we found here was that we looked at all the steps in the care pathway. This is all basically done. It was done through a few ways: chart abstraction. It was also done through actually going through the clinic and looking at whether they had signage in the waiting room. Does the practice, from my mental standpoint, look like it cares about mental health? And we also looked at their practice policies and procedures. But the primary thing that came to the score was the chart abstraction. So this is the total score. The PrEP-D stands for the practice readiness to evaluate and address perinatal depression. And so you can see that in MCPAP for moms, the total score didn't change. This was pre-implementation to 3.5 years post-implementation. This was not significant, and none of the actually steps in the care pathway were significant, nor were the overall scores. However, for PRISM, it was. You see a difference in the overall PrEP-D score. You also see a difference for screening for depression and for bipolar disorder with the mood disorder questionnaire. And we saw a change in practice policies and procedures. We didn't see it for assessment, treatment, follow-up, and monitoring. I suspect that's because they weren't documenting it, because these are OB surgeons who don't write a lot in their notes. But, you know, we can't say that. But working with them, I think they were doing more of this, but I think the way we recorded it may not have captured that. But regardless, we definitely see a difference in the overall score and certainly in the screening and the policies. So that's the fidelity of the care pathway. The next thing we looked at was treatment initiation. As I kind of said in the very beginning, our group had done a systematic review, and we found that even if a woman screens positive for depression, unless there's a system in place, less than a quarter of those people are going to get even to an initial mental health appointment. And studies either have shown that they either don't follow up or it's just not recorded. So extremely low rates. What we found in our study is that with MCPAP for moms, treatment initiation was 43%. In PRISM, it was 52%. And then for treatment sustainment, it was 20% with MCPAP for moms and 25% with PRISM. So PRISM a little bit higher. This difference was not significant between the groups. So as far as changing treatment participation, one would say they're equally effective, but you do see there's a trend that the rate's greater in PRISM, but it was not different between the groups. Then we looked at the depression symptoms. We looked at when they were recruited, and they could have been recruited either first half of pregnancy, second half, or postpartum. And again, followed them till a year postpartum. They entered with both groups with a mean EPDS of about 13, a little bit lower in the PRISM group. And the mean EPDS at the end of the study was 8.5 for both of them. So this was not what we were expecting, because MCPAP for moms essentially helped a lot more than we would have thought. We hypothesized, to remind you, we hypothesized 2-point difference in MCPAP, 4-point in PRISM, 2-point difference of differences. Both groups, we saw about a 4.5-point change in the EPDS, with PRISM being 0.1 greater improvement. So what this tells us is that they're both equally effective, at least for changing depression symptoms, they're equally effective. The cool thing about this is that MCPAP for moms is now in 19 states across the country. It's far more scalable. So in some ways, this is good news because it worked a lot better than we thought it was going to. And the association is much stronger than we thought we would find. So the other thing I want to comment on is on reach, because when we did this study, we were looking at effectiveness. We looked at to what extent is it changing treatment rates, to what extent is it changing depression outcomes. But when we think about implementation science, there's a concept, the RE-AIM is one of the frameworks that we use, implementation science, and RE-AIM sort of posits that impact is reach times effectiveness. So the results I just presented were all about effectiveness, right? That, to what extent did it change the treatment and the depression scores. What we didn't do in the study was we didn't look at the reach. If you go back and look at this slide here, you could see that I think PRISM must have been reaching more people because they screened a lot more people, right? And they were implementing depression care better. So the quality of care changed and they were screening a lot more people. So I would think that it likely reached more people, but we didn't look at that. And so we can't say, while I hypothesize that, we can't say that because we did not look at the denominator. We looked at 30 patients from each of these 10 practices. We didn't look at the denominator. So we didn't look at to what extent were each of the patients in the practice reached. So that's what we need to do for other studies. And particularly looking at that by race and ethnicity and doing that with an equity lens, which I'm happy to answer questions about. I didn't present that because of time, but so in summary, what we found was that both interventions improved treatment sustainment and treatment initiation rates both improved depression outcomes. And PRISM did change the quality of care that the practices were providing. And the link between those two, we need to further understand and do more research on. So, and a huge thank you. This was a long study that, took us almost 7 years. And just a huge thank you to all the many people who were involved in this study and to our funders, the CDC. Thank you.
Great. And our next talk, and thank you so much. We're going to do joint Q&A session at the end. So our next talk is going to be by Tyler Tirico, titled Determinants for Custody Under Child Protective Services for Newborns of Mothers with Inpatient Psychiatric Hospitalization.
Oh, great. Thank you. All right, let me get this loaded up for everybody. Okay, so my name is Tyler Tirico. I'm a PGY3 resident at Kern Medical in Bakersfield, California. I'm also an APA SAMHSA Minority Fellow, and this study was kind of inspired by some patients I saw in my intern year. So it's called Determinants for Custody Under Child Protective Services for Newborns of Mothers with Inpatient Psychiatric Hospitalization. My mentors and co-authors, Dr. Tawhid Salam and Ranjit Patty, they're not here, but they helped me a lot with this project. I have nothing to disclose. So the objectives of the research project were to estimate the prevalence of CPS-directed custody arrangements at the time of delivery for patients with psychiatric hospitalization during their residency, and their pregnancy, I should say. And like I said, this was inspired by when I was an intern, new on the inpatient unit, had a few patients come through that were pregnant, psychiatrically hospitalized. Well, what happens after, right? They eventually leave the hospital. What's happening after? Are they parenting these children? Are they going to CPS? What is happening? So I decided to follow it up. So we're investigating which risk factors were associated with custody arrangements with CPS at the time of the delivery after the hospitalization was complete. And then, of course, another objective, we want to raise awareness to any of these variables that are modifiable that could improve parenting outcomes. So background. So as we just heard in the previous talk, perinatal mental health disorders are among the most common morbidities and mortality in pregnancy. Mental health in pregnancy has significant contribution to maternal morbidity, as well as adverse outcomes for the neonate, infant, and child. Mothers often report tremendous psychological impact after CPS surrender, and there are reports of worsening mental health, legal problems, and coping with drugs and alcohol after a CPS surrender occurs. CPS surrender is often stigmatizing, and mothers may face social judgment for failing in assumed parental responsibilities. So in 2020, SAMHSA released data that showed that 14.2 million or 5.6% of adults in the US qualify for serious mental illness, which is defined as impairment with a major life activity, of which parenting would be one. So those suffering with serious mental illness frequently require utilization of inpatient psychiatric hospitalization. The prevalence of parenthood between individuals with and without serious mental illness is similar, despite those with serious mental illness having higher likelihood for CPS contact and CPS-related custody arrangements than their counterparts. CPS involvement has disproportionately impacted families marginalized by poverty, mental health disorders, and substance use disorders. So diving into how we went about this, we did a 10-year retrospective chart review from 2012 to 2021 at our hospital in Kern Medical in Bakersfield, California, which is a community safety net hospital. We'll see anybody, regardless of insurance or not. If they don't have insurance, they come to our hospital in the county. So we see everybody as a safety net. This is where it was conducted, and that will reflect in the patient demographics that I'll show. So qualifying subjects are those with inpatient psychiatric hospitalization during pregnancy. The primary outcome variable was whether or not the newborn had custody arrangements directed by CPS. And we looked into OB history, social history, medical history. We utilized logistic regression to look at the study outcome and the variables we looked at. So we had a few exclusion criteria as well. over those 10 years, we had 85 patients that were pregnant and psychiatrically hospitalized in our unit. 2 had intrauterine fetal demise. They were excluded from the study, of course. And then 2 were lost to follow-up. So we had no idea what happened afterwards. But that left us with 81 patients that we could track and see what happened at the time of delivery. So the gross results for the whole study cohort was kind of shocking. So 64% or 52 of the 81 had CPS-directed newborn arrangements, and 29 or 36% were going home with the mother. So about 2/3 to 1/3. So really the minority are taking the child home. So looking further, our table 1, it shows the social demographic and clinical features of this patient population and a univariate analysis for the CPS-directed custody. So our first column shows the different variables. The next column is going to show the full cohort. The next column, CPS negative, this is where the mother takes home the child. The third column is where CPS is positive. So there are CPS-directed custody arrangements. And then we have the associated p-values. So something that was interesting, and I'll get more into these details in the multivariate analysis, but a few that stand out here would be insurance. Like I mentioned, we're a safety net hospital, so the majority of our patients have Medi-Cal, but we did have 6 pregnant patients come through that had private insurance, and they had a stark contrast to those with Medi-Cal, where those who had private insurance were much more likely to ultimately parent and take home their child rather than have a CPS-directed custody arrangement. In the numbers, they're quite small on my end, but it looks like 5 took home their child, whereas 1 had a CPS-directed custody arrangement, compared to the Medi-Cal group, which the majority are going to be going by CPS-directed custody arrangements. Other significant variables were those who were unemployed, had no prenatal care, had an incarceration history, a history of homelessness, and then we also looked at the diagnosis category for those, the reasons they were hospitalized. So those with a psychotic disorder, those with a mood disorder, and those with a psychotic disorder were much more likely to have CPS-directed custody arrangements than those with a mood disorder. And we also looked at substance use in pregnancy, which is cited as a major reason why there's a CPS-directed arrangement in the first place. And we did see that there was significance with any substance, so looking at all the substances combined, and then we broke it down by individual substances. Cigarettes and methamphetamine remained significant, but cannabis did not. So moving forward with the multivariate analysis, we ran a bunch of different models, and this shows some of the more interesting ones. But the overall prominent trend that we saw after controlling for the demographic information was that psychotic disorders, if you had a psychotic disorder or a history of homelessness, that was going to be most predictive of having a CPS directed custody arrangement, whereas everything else on its own kind of normalized out. And again, the reason we use psychotic disorder rather than schizophrenia, schizoaffective disorder, bipolar disorder is in the community setting, it's rather challenging to get a firm, concrete diagnosis with all the concurrent substance use, limited time for evaluation in the inpatient setting. So we grouped together everybody who had psychotic symptoms versus those who did not. So again, psychotic disorder and history of homelessness were significant after controlling for the different variables. Now, since we had these 2 variables, we wanted to see, well, if you have one or if you have both, does that increase your risk further? So we made some subset variables looking at if you had no history of homelessness, didn't have a psychotic disorder, and then if you had homelessness without a psychotic disorder, had a psychotic disorder but no homelessness, and then if you had both homelessness and a psychotic disorder, to see if this remains significant. And what we see, I've kind of graphed out here, is that if you have one of the variables, the odds ratio for having a CPS-directed custody arrangement goes up by about 10, but if you have both, it jumps up to about 44. However, the significance for that jump to 44 was not maintained. So it would be nice if we had a longer study to look at if we could get that significance there in a bigger study, but it does make a big jump if you have both history of psychotic disorder and history of homelessness. So just talking about these results and what they mean for clinical practice, although all patients with serious mental illness are more likely to have a CPS custody arrangement than their counterparts, those with psychotic illness have the highest likelihood. And you can keep this in mind when you have pregnant patients that are being psychiatrically hospitalized, of course. Psychotic illness is generally debilitating. It's associated with socioeconomic disadvantage, and it may further perpetuate difficulties in the ability to raise children. Any history of homelessness, regardless of the type of mental illness, had a high likelihood for CPS-directed custody arrangements. And again, homelessness, there's a difference, current homelessness and having a history of homelessness, which would encompass both. And there's a whole subset of research that people are doing, looking at if you've ever been homeless, does this predispose you to adverse, not only mental health risks, but also physical risks too. And so this adds to that literature. Although the sample size of this study is relatively low, we did have statistical significance to suggest power for a few of the risk factors. So potential interventions. This first one is easier said than done, optimizing the management of psychotic illnesses, right? This is kind of our all shared goal for patients with schizophrenia. It's easier said than done, but this is another reason why we'd want to manage that, because as we've seen, a lot of our female patients do end up becoming mothers, and then there is the effect of the children having, right? If they're either with them or they're not, the patients tend to talk about that and it affects their lives. So history of homelessness has been previously associated with additional adverse health outcomes I just mentioned. So there's a continued need for public health interventions aimed at reducing homelessness, which just continues to spiral in America. And then the last thing I wanted to mention and talk about was there's really a window for improvement of physician-guided family planning discussions for patients with serious mental illness, in connections to services that may provide contraception if it's desired. A lot of our patients, the only time they're seeing a physician is when they're seeing a psychiatrist, and that can be either voluntarily or involuntarily. A lot of them are not seeing other physicians. So if they wanted to have the opportunity to have a physician-guided family practice session, it would fall on the role of the psychiatrist, who you may be the only doctor they see that year or within a few years, to be honest. And from what I've seen in my limited experience as a PGY3, this tends to come up when we're prescribing medications that have teratogenic effects, right? That's when we're going to talk about pregnancy. But there's really more of an opportunity there. Maybe your patients aren't thinking about getting pregnant, but you can spark that. Hey, are you planning for contraception? Are you planning to have a family? Can I connect you with those kinds of resources? So that's another intervention that we can look at too and improve in our practice. But yeah, so the summary of this, it would be that those with inpatient psychiatric hospitalization while they're pregnant, if you're looking at CPS-directed outcomes versus motherhood and taking the child home, the risk factors appear to be having psychotic symptoms as well as having any history of homelessness. And those are my references, and I'll be around for the Q&A.
All right. For our next talk, we're going to have Marissa Beal talk to us about frontline interventions for perinatal psychiatry, the utility of informational guides to improve psychiatric education for obstetric providers.
All right. Well, it's good to be here. Hopefully you guys can hear me okay. So I'm Marissa Beal. I worked on this project as a fellow with two of my supervisors, Lindsay Standevan and Lauren Osborne. And also just want to mention Samantha Melman, who was one of the social workers who worked on this project with us. And as was mentioned, I'll be talking about frontline interventions for perinatal psychiatry, what we call the FLIP guide, and the utility of informational guides to improve psychiatric education for OB providers. I don't have any financial disclosures, but I do want to mention that our frontline intervention for perinatal psychiatry, the FLIP guide, was actually adapted with permissions from some of the toolkits that were at MCPAP for moms. So they have a great set of toolkits for identifying perinatal mood and anxiety disorders, as well as substance use disorders. So we've heard this, we know this, right? The perinatal period is a time of increased risk for mood and anxiety disorders, and there are really significant barriers, right, to accessing psychiatric care during the perinatal period. And this is especially true for patients with low socioeconomic status. And really, OB-GYN providers are at the front line of care for these patients. And there are recommendations, right, from a lot of organizations, including ACOG, who recommends screening for depression and anxiety once in pregnancy and once in the postpartum period. and also to start treatment actually, and or to refer to behavioral health services as indicated. And there was actually the Council on Patient Safety and Women's Health Care developed a safety bundle with recommendations. And these recommendations are to, screen, identify, and treat perinatal mood and anxiety disorders in the obstetric setting. And so what we're seeing is that these societies are making these recommendations for OB providers to be doing this level of care, and yet OB providers feel that they don't have adequate training to manage psychiatric illness. And there's a couple studies that have been done asking program directors how they feel in regards to OB-GYN residents being equipped to actually identify psychiatric needs. And there's been determined to be really a gap in training in this area. And some of the barriers that they identified were a lack of integration with psychiatry and OB-GYN, the demands of surgical training, and ultimately a lack of knowledgeable instructors to provide this information. And so what we wanted to do in this study was to assess OB-GYN providers' comfort level with identifying and treating mental health disorders during the perinatal period. We developed the FLIP guide, the Frontline Intervention for Perinatal Psychiatry. We then disseminated this guide, and then we wanted to determine the use and the barriers to using this guide. And so our FLIP guide included 3 different measures: the EPDS, the PASS to look for anxiety, the MDQ for bipolar disorder. We included screening algorithms for depression and bipolar disorder. We included a risk-risk discussion, so including the risks of untreated or undertreated depression versus the risks of SSRIs and SNRIs. We added a treatment algorithm for perinatal depression, guidelines for managing a patient on lithium during pregnancy and during delivery, and then lactation considerations. These are some of what's included in the guide. It's not the complete thing, but this is some of the lactation guidelines. So we included sort of a link to LactMed so that the OB providers could utilize that, and some general thoughts about it. So SSRIs and SNRIs are generally safe, and also the importance of preserving sleep in the postpartum period. And this was another part of the FLIP guide. This is managing the patient on lithium during pregnancy and during delivery. And so these are general practice principles really for women with bipolar disorder during pregnancy. And then we also wanted to give them some guidance on how we manage lithium during pregnancy and specifically during delivery, because these questions can come up for providers. And so these were our methods. So we identified OB-GYN providers at 2 of our institutions, so at Johns Hopkins Hospital and Johns Hopkins Bayview Medical Center, via email or via resident didactics. We completed a pre-intervention survey, and at the end of the survey, they were able to actually download the FLIP guide. They had to then save it on their computer or onto their phone in order to use it later on. And then we did a post-intervention survey that was about 2 months later. And so our hypotheses were that OB-GYN providers overall wouldn't feel equipped to identify and treat perinatal mood disorders, and that utilization of this guide might improve comfort levels over time. And so our pre-intervention demographics included mostly women. We had 54 females and 3 males, mostly resident physicians. We did have some attending certified midwives and nurse practitioners, and then residents were across all 4 years. And so these are some of the answers to the survey questions from our pre-intervention survey. We initially asked how often do providers use scales to assess mood symptoms in pregnancy. And unfortunately, as you can see, it's sort of across the board, which is unfortunate. It means there's really sort of nothing systematic happening, at least at our institution, in regards to screening. So some people said never, and some said sometimes. We also asked how often providers recommend stopping antidepressants during pregnancy. The positive of this is that most said never, although we still have a big group that's saying sometimes and a couple saying always. So that's a little bit concerning. We then asked about the comfort level with prescribing antidepressants during pregnancy. And this was a little bit surprising to us. We actually thought they would be less comfortable than they said in this survey. So at least 75% were at least slightly comfortable. And so this trend was a little bit different than what we were expecting. And when we asked why, so why did they feel uncomfortable prescribing if they did, most of the reasons were not enough training to have an informed risk-benefit discussion. They were concerned about follow-up, or they didn't recall medications or how to prescribe. We also asked about comfort level during prescribing antidepressants during lactation, and similar trend is what we saw before. So people overall felt comfortable prescribing antidepressants during lactation. About 70% felt at least slightly comfortable. And we asked about reasons why they felt uncomfortable prescribing during lactation. And the biggest reason was not enough training to have an informed risk-benefit discussion, or they didn't recall medications or how to prescribe. We also asked if providers felt they had sufficient training to treat depression and anxiety in pregnancy. And we see that 53% said yes, they did feel comfortable, or they felt that they had sufficient training, and 47% said no. When asking about comfort level with other psychiatric diagnoses, such as bipolar disorder, personality disorder, or substance use, they felt less comfortable than when prescribing during pregnancy and lactation for mood and anxiety disorders, but overall still 58% felt at least slightly comfortable. And when we asked about comfort level with managing women on lithium during delivery, clearly they felt less comfortable with this than the others. 66% felt at least slightly uncomfortable. We then completed our post-intervention. Unfortunately, it's really hard to get people to respond to surveys, especially after a time lag. And so we only had 12 respondents, 11 women, same thing as before, mostly resident physicians, but at least a couple attendings and a nurse practitioner. And the same thing, residents across all 4 years. When we asked about providers, if they actually read the guide, so the positive is over 80% said they at least read all or some of it. And when we asked why they didn't read the guide, most of them said they forgot about it or they didn't have enough time. And we asked if using the guide increased the use of scales. And what we see is at least 44% felt like it did increase their use of scales. And so in general, right, our results were a little surprising in that providers at our institution felt comfortable prescribing during pregnancy and lactation, or at least more comfortable than we expected. Many, though, at least 47% felt that they didn't have enough training to manage psychiatric disorders, and this was the most common reason for discomfort. And when we saw in the post-intervention, most providers actually did use the guide, and use of scales increased in about 44% of respondents. So the limitations for this is that there's really a small number of respondents in the post-intervention survey, so it's really hard for us to really know how useful this was. We were limited to one institution, although we did have 2 different sites. And there's a possible sampling bias. So people who may have been more psychiatrically inclined may have been the ones who responded to this survey, and maybe a response bias as well. Perhaps they thought we wanted to hear that they felt comfortable prescribing. And what would we do differently? Unfortunately, this was a QI project. And so our pre and post surveys to compare comfort level over time were different. So we weren't actually able to compare pre-comfort level and post-comfort level. So that was sort of an error on our part. And I think for me, the interesting thing is if comfort is not the issue, what is the other issue? So why aren't they actually prescribing? And so one thing we wanted to assess for in the future was maybe time, if time was a barrier, and also to really identify like what are providers actually doing? If they do feel comfortable, why are they not actually screening? And what are they actually doing with prescribing? I mean, I work in an integrated clinic, and so sometimes I see patients like 2 months after and they haven't been started on any psychotropic medications. And so to me, that's there's a disconnect here, right, between their comfort level and their actual prescribing practices. And so for us, future directions are really to identify the best strategies to engage OB-GYN providers in education. And we want to think about alternate modes of delivery for this kind of educational guides to improve engagement. So we talked to some providers about maybe having it app-based so that you could actually have it on your phone and open it up instead of having to look back for this PDF that you may have downloaded months ago. And also thinking about other multimodal educational strategies. So how do we engage providers in like active learning? And we're working on sort of a partnership between National Curriculum for Reproductive Psychiatry and AGOG to help develop an educational content in addition to educational guides like this. Yeah, and that is it. These are my references. And I will keep going.
All right, moving along. So our next presenter is Sarah Carlini, who's going to be presenting about inpatient obstetric consults at a large academic medical center, service utilization, and targets for quality improvement.
Oops. Hi, everyone. I'm Sarah Carlini. I'm a recently graduated consultation liaison psychiatry fellow from the Northwell Health program in New York, currently working as a consultation liaison psychiatrist at Maimonides Medical Center, and really happy to have the opportunity to be able to present some data to you that I collected as a fellow, on behalf of myself and my co-authors here in this talk entitled Inpatient Obstetric Consults at a Large Academic Medical Center, Service Utilization and Targets for Quality Improvement. I and many of my co-authors have no disclosures. Dr. Del Giannides, one of my co-authors, has some disclosures listed here. So as the excellent presentations, preceding mine have established, perinatal psychiatric disorders are distressingly common, with a 12-month prevalence of, almost around 25% in pregnant and postpartum women. Despite this, we struggle to reach folks, and to kind of treat them with, one data set suggesting that only about 30.8% of women are identified, with these needs are identified in clinical settings, then maybe only 15.8% are treated, then maybe only 6.3% are treated adequately, and only 3.2 treated to remission. So in terms of rates of psychiatric consultations in inpatient obstetrics, generally the rates that are published and that are available out there are low. 0.7% per one study, 2.5% for another, with one recent outlier coming from Canada, Sloan and Kirsch in 2008, found that at their hospital they had about 18%. So the purpose of this QI project was for us to determine the rate of inpatient obstetric service utilization of CL psychiatry in our, large academic medical center of Long Island Jewish Medical Center, and to really characterize these consults per demographic and clinical variables to understand why we're being called and what we're being asked to do to hopefully improve, our ability to respond to this need. So as I said, this is a QI project conducted at Long Island Jewish Medical Center, which has about 7,500 births per year, so a large birthing center. The thing to know about our our internal process is that social work on the obstetric floors sees patients initially and performs an assessment, and per their assessment, CL psychiatry is consulted if there's a need. We looked at data from January 1st to December 31st in 2021. These records were identified initially through billing data, and once we had those cases identified, we used retrospective records review to extract the qualitative and quantitative data points that we were interested in. So we had 63 consultations on pregnant and postpartum women on the obstetric service for the year 2021. That was only 2.4% of the psychiatric consultations for the entire year, only 0.8% of births. The average patient was seen 1.5 times, just kind of a funny number. It just means that mostly we saw people once, and there was a small group of people who were followed, thereafter. Now, just kind of briefly for demographics, the majority of our folks that were seen were Black, married, not Hispanic or Latino, and overwhelmingly folks were seen in the postpartum. 90% of people were seen after having given birth. Interestingly, 30% were already in outpatient psychiatric care, and 27% were already taking psychiatric medications. In terms of religion, our sample was overwhelmingly Christian and Catholic. So I sought to characterize these consultations into two major types. The first major subtype is consults that were called because of an active psychiatric symptom that was being reported or an acute behavioral management concern. This was the majority, 59% of consultations, and you can see that far and away it's for depression and anxiety. That was the major concern, with some consults being called for agitation, capacity, etc. Now, in some of these cases, 43% of these cases, there was actually a psychiatric symptom scale that was available, that was performed by obstetric social work, and it was either the Edinburgh Postnatal Depression Scale, the EDPS, with an average of 14, rather large standard deviation, or the Patient Health Questionnaire 9, PHQ-9, with an average of 12. That puts people squarely in the moderate depression category. Now, there is a subtype I want to talk about for consultation subtype 1 of folks who had active psychiatric symptoms. For a good portion, 41%, almost half, these symptoms were occurring specifically in the context of an adverse obstetric event. I think this is really important, for this population. An adverse experience in labor and delivery, of which there can be many, unexpected C-section, postpartum hemorrhage, fetal distress, preterm labor. Interestingly, postpartum preeclampsia, a rather large number, 29%. I'm going to avoid the diversion because there's kind of some interesting things to say about that, but in the interest of time, fetal and neonatal demise, unfortunately, another big category, and then post-surgical complications. Now, this other major subtype, if subtype 1 was active symptoms and subtype 2 is no active symptoms, just maybe a history of a psychiatric diagnosis or, of a major, psychiatric concern or symptom. Now, this was almost half, 41% of consultations were called on people that had no immediate psychiatric need. Now, often as CL psychiatrists, we're really used to being called for psychiatric clearance, for psychiatric clearance for discharge rather. So sometimes this was the way that these consultations were phrased. And now you can see that 50% of the time the concern was past suicidal ideation or past suicidal behavior. And 27% of the time that it was a past history of bipolar disorder that was concerning to the team that they wanted us to comment on. And then fewer cases for depression, schizophrenia, and kind of multiple diagnoses. So just briefly for the consultation outcomes, you can see a very long list of, diagnoses. As is perhaps not unexpected for consultation liaison psychiatry, 50% of the time, 52% of the time, adjustment disorder was really the most appropriate diagnosis. But you can see what a wide range of diagnoses were really represented in this sample. Now, around 27% of the time medication was indicated. For the most part, it was an anxiolytic at 47%, but there were some times where antidepressant and antipsychotic was started in the inpatient hospital. Interestingly enough, for this year, none of these folks were immediately psychiatrically hospitalized. I will say, just from being a trainee in the system, some of these folks didn't do so well in the weeks and months after birth and ended up psychiatrically hospitalized, but no one in this year went from CL consultation on the obstetric floors directly into a psychiatric hospitalization. So two major things I want to focus on in the discussion. One is to talk a little bit about this low consultation rate, this low CL, psychiatry consultation rate on the obstetric floors, and also to spend a little time on this concept of the non-acute symptom, consultations happening in 41% of cases. There might even be some folks, you might think, well, is this an appropriate use of CL psychiatry to come in and see folks who are not have no active psychiatric needs. So our 2.4 is interesting, right smack dab in the middle of most of the data for what's out there. It seems reasonable to suggest that symptoms that are maybe not present yet, or that are subclinical, or that are developing, or just not being captured in this very brief length of stay, labor and delivery window, that kind of calls to mind, putting on the QI hat of, is post-discharge follow-up for the inpatient obstetrics a way that we could potentially catch folks who are maybe developing symptoms but they're just not acute enough yet to kind of for us to see that signal. Now at LIJ, there's this great model of following folks who are at elevated medical risk, and it seems like a great opportunity to either borrow that model or ideally maybe to kind of interdigitate with what they're doing and maybe add in a PHQ-2 and see if we can, kind of widen our net in that way. Now, so being asked to see folks who are not currently having symptoms, and I think just, as again, the wonderful talks that have preceded this, prevention is so important. Prevention and psychoeducation are critical. Yes, it is important for us to kind of provide. I think if we're being asked to stratify risk as CL psychiatrists, we should come in and stratify risk, but it's also an opportunity to provide psychoeducation and anticipatory guidance. If I could borrow a term from the pediatric medicine world, to women on what may happen, what they may be at risk for, and how to prevent psychiatric decompensation. It's a great time to tell folks with a history of bipolar disorder, if they haven't had a chance to speak with a mental health provider, or a reproductively informed mental health provider, that they've got to protect their sleep in the postpartum. So we can really, I think, do a lot of good even in a short window here. Now, standardized written education, as we just heard about, is very important, and I think should just be a part of, kind of supplementing our consultation, and also supplementing what folks are getting, again, if they're not quite rising to that level. So that's a kind of a major, fertile, ground for further quality improvement. I also, near and dear to my heart, I think this is a great potential there's a great potential role for integrated behavioral health in the obstetric floors, to have an integrated behavioral health provider who's really there, maybe even kind of using, the model of proactive CL to identify who needs to be seen and who could really use, again, 30 to 45 minutes of counseling, bespoke, tailored counseling to their psychiatric history. And I would be remiss if I don't, mention and kind of amplify the message that we've also heard, that antenatal identification of behavioral health concerns is critical. And I think integrating and, supporting folks in ambulatory OB, maybe even being a part of ambulatory OB, to make sure that ideally the first time folks are being identified and having these conversations is not at the time of labor and delivery, it's before. It's when they first start engaging in prenatal care. So the limitations of this data, this is a very specific institutional context. We did only look at 1 year, although we hope to look at more years to kind of establish more of a pattern. It's a retrospective data analysis. We all know the kind of weaknesses that can go into, this type of research. And here are my references. And I just want to briefly thank our wonderful administrative coordinator, Marinel Mejia, who pulled the billing data that allowed me to do this work. And I also just want to quickly thank the Feinstein Institutes for Medical Research at Northwell Health. They did support some of this work, and it was really lovely.
Thanks so much. All right, and our final presentation before our Q&A session is going to be given by Andrew Drysdale, and his talk is entitled "Using Neural Subtyping to Examine the Heterogeneity of Postpartum Depression."
Okay. All right. I have no disclosures. All right. Thank you for the opportunity to talk today. This is sort of the culmination of my Webb Fellow Prize that I got last year, although this work is still very much ongoing. So today I'm mostly going to describe background and our experimental design. So the work I want to talk about today is all about trying to break apart heterogeneity in depression. We all know that depression's a very, very heterogeneous disorder. People can meet criteria appropriately with dozens of different combinations of symptoms. Their clinical course and severity and all these other factors can look much different across people that are all appropriately called depressed. So I've long wanted to understand this heterogeneity, to see if it would reveal something, if we could find more homogeneous subgroups of patients. This would tell us something more about the mechanisms of depression, if they're separate disorders, and tell us what treatments people might respond to. This is not just my idea. This is a common idea in psychiatry for years now, that we could break apart patients with a variety of sorts of data to try to actually find more homogeneous subtypes of depression or whatever disorder we're talking about, design clinical trials around that, and then eventually predict what treatments people would respond to. You could do this at a number of levels of data, genetics, various kinds of physiological biomarkers. And I previously was part of work trying to do this using neural connectivity. So when I say neural connectivity, we were using whole brain resting state functional MRI. So for those who are less familiar, essentially in resting state fMRI, people sit in fMRI, look at a screen with a fixation cross, and simply try to stay awake. There is no task. And they have to keep their eyes open. That's the only instruction we give them. And basically, we measure spontaneous activity across any region of the brain throughout those scans. And then essentially, if you look at the correlation between spontaneous activity in one region and another, that's what we call functional connectivity in this context. We used a whole brain approach. So we broke up the brain into 250 or so functional regions, and then looked at the full connectivity matrix, comparing every region to every other region throughout the brain. And you end up with a big graph like this. This is the group average connectivity matrix. There's kind of common patterns that you'll see across people pretty consistently. Nodes within a given network, like the default mode network, that's the bottom row here, all tend to positively correlate with each other, and they negatively correlate with some other classic networks here. But if you look at the same matrix in any given individual, there'll be lots of subtle differences. And we want to try to leverage that to better understand how that might relate to people's depression. So in a whole host of patients with depression, I'm talking about hundreds of scans, we used a method called canonical correlation that looks at the correlation between two sets of data. In this case, it was clinical symptoms and their connectivity. And it reduces those relationships down to basically a principal components like dimension. So then you can look at this in a much simpler sort of space. So we ended up with two of these symptom connectivity dimensions. One of them was heavily related to anhedonia and psychomotor retardation, and on the clinical symptom side. So on the connectivity side, we call this anhedonia-related connectivity. And it was really weighted on a lot of frontal striatal circuitry that is classically involved in reward. The second dimension we called anxiety, based on its weighting on anxiety and insomnia symptoms. And on the, again, in the brain side, it was heavily weighted on frontal limbic circuitry that's classically related in emotion regulation. So then we have this way of kind of more simply looking at every single patient based just on our neural connectivity in these dimensions. And we sort of plotted people out along these dimensions, just visualized here on two axes. And you can do this just with someone's scan at this point. And so then after we plotted out every individual, we used a clustering algorithm to try to find, are there sort of reliable subgroups looking at people in this way? And we identified 4 subgroups based on connectivity of depressed patients. These subgroups were pretty consistent, whether you, no matter which individuals you included in the calculation of these subgroups. In a subset of people who we had multiple scans on over the course of a few weeks, they were consistent over time. In a subgroup of people who went on to have a specific TMS treatment, it actually helped predict who would respond to that treatment. So since doing that work, I did psychiatry residency and just finished CL fellowship last year. And I wanted to continue on in this work in a way to try to better understand, what do these connectivity subtypes actually mean? Are they showing us separable underlying mechanisms by which people might get to depression? And does where people lie on this sort of way of understanding their connectivity actually tell us what treatments they would respond to much more broadly? I think you've heard from a lot of people today why perinatal depression is a vital and very interesting clinical population. I would also argue it's a potentially optimal research population. So to try to make this approach a little more straightforward, we wanted to look in a potentially more homogeneous population. Certainly, I don't believe that perinatal depression is just one disorder with one cause and every single person who suffers from it, but it might be more homogeneous than sort of every person with major depressive disorder. There's definitely clinical evidence of some symptom level heterogeneity. So we wanted to start with kind of the most narrowly defined population we could. So we're now focusing on people with postpartum onset only. Compared to other mood-related depressive disorders, this is a relatively healthy population, fewer medical confounds, and exciting from a scientific point of view, because there's the predictable at-risk period when people are going to develop or at risk for developing perinatal depression. I could potentially see what happens in one person's brain before and after they develop depression. And there's also pretty well-developed lines of inquiry of various potentially disorder-specific mechanisms leading to perinatal depression at a couple of different levels that we can use to sort of anchor this connectivity way of looking at people. So the aims of this project are to use this connectivity-based approach to look at subtypes in postpartum depression, to then link those connectivity differences defined in this resting state scan to actual functional differences in that same neural circuitry. And then finally, to compare potential biomarkers of postpartum depression across these subtypes. So I'll describe each aim in a little more detail. So the first is essentially using that same approach I described in major depressive disorder and postpartum depression. That's basically getting new scans and running them through the same algorithm that we did before to see what subtypes they would be assigned to and whether they end up tending to fall within a smaller, more limited range of these subtypes than all major depressive disorder, which I would predict they will. Now, it may sound simple, just get new scans, throw them into an old algorithm, but unfortunately it's much more complicated than that. There is a good reason to use the old algorithm, which is that to redo this from scratch would require hundreds and hundreds of scans like that prior study did. So we really do want to be able to use this existing algorithm. There's a couple of methodological challenges that I'm currently working on. One is that, so the initial approach was somewhat prone to what we call overfitting. Connor Liston, who was the PI on that project, has continued work in his lab and updated the method somewhat so to address this problem. And so we're working on integrating his updated methods. Beyond that, that work was done down at Cornell. I'm now at Columbia, and there's actually a lot of very careful corrections you need to do for doing this across a new scanner and new site, so that you're assigning people to a subtype based on their actual connectivity and not just where they happen to be scanned. So those are sort of control experiments that we're working on right now. So for AIM2, like I talked about, those dimensions, although they're in seemingly relevant areas of the brain, the connectivity features are in seemingly relevant areas of the brain to the symptoms they were linked to. They don't necessarily have a functional meaning. This is defined at rest and people are just sitting there. So we wanted to actually see if these people do have dysfunction in underlying neural circuitry like we think they will. So for that, we're going to use active fMRI tasks. Specifically, we're going to use a reward task to look at reward-related activation in the ventral striatum and see if that correlates to where people lie on the anhedonia connectivity dimension. In the same way, we can do that with an emotion regulation task. For those of you familiar using the reappraisal task, look at how bringing back up negative memories activates people's amygdala, and whether the amount of amygdala activation correlates with where they lie in this anxiety-related dimension defined by resting state fMRI. Okay, now finally, biomarkers. So there's decades of research into some potential specific mechanisms to postpartum depression. So the mother-infant dyad is a rich area of research in this regard. There's a lot of careful studies of cognitive biases towards infant-related stimuli in people suffering from perinatal depression. And likewise, there's a whole spectrum of literature relating various reproductive hormones at different stages of pregnancy to depressive symptoms. But the findings across the literature are pretty variable and sometimes in contrasting directions. And this is an important thing to figure out because there's actually treatments aimed at each of these lines. So there are mother-infant dyadic interventions that have been shown to work, at least in some people. And now we know brexanolone, the infusion of a neuroactive steroid that is a powerful treatment for postpartum depression, but also still has kind of variable response. So the hope is that if we could better find more homogeneous groups in these biomarkers, we might be able to know what treatments people would respond to. So for AIM3, we're going to measure these things and compare them between these connectivity subtypes. So for now, we're measuring serum allopregnanolone, estradiol, and progesterone, as well as we're doing a cognitive task to measure infant-related attention. And we're going to compare these biomarkers between the connectivity subtypes. So right now, this is a big new project with new data collection for me and all of my mentors. So we still have our IRB under review and working on the method stuff that I talked about up front. In addition, looking to fund this full study requires some additional pilot funding. So that's one of my current aims. I wanted to thank my institutional web fellow mentor, Peter Shapiro, back at Columbia, our division director. I have continued on since clinical fellowship into a research fellowship at Columbia, and I have this collaborative mentorship team there who've been great. I'm continuing to work with Connor Liston, who's at Cornell, and he was the PI on this depression subtyping project, which was itself a huge collaborative international study. So thank you very much for your attention. I guess we'll all take questions together.
Yeah, it was an amazing job staying on task. So we have a good amount of time here for questions. So please step up to the mic if you have a question to ask and address our speakers here.
Right. So howdy, I'm coming from Brown, and this was a really great group of presentations. I have a question for our last speaker. So with the functional connectivity, and maybe I missed this, do you have differences in imaging between non-pregnant women and pregnant women in terms of connectivity? Because my understanding is that there are connectivity changes just related to becoming a mother. And then within the subtleties of that, and this may be like way beyond the, like you need to narrow in to get a project. But my other understanding as well is, you know, things like adverse childhood events, ACEs impact that connectivity. And so that may be some of what you're seeing in the differences. And then one last question, because I have a million of them. Are these women stratified into breastfeeding, non-breastfeeding, and what might be the impact of that? Okay, I'll shut up.
Those are all really great questions. Let me see if I can remember each of them. But so yes, there are definitely brain changes sort of before and after pregnancy. There's been some really interesting work that was published in the last few years on actual structural changes that seem to be long lasting after pregnancy as well. And from that work, it looked like some of the structural changes, at least, were in this sort of network of regions that are responsible for things like theory of mind and maybe infant related attention and things like that, that need to be fine tuned during and after having a child. So I do believe that those sort of changes will be really important here. We're not going to scan during pregnancy. I would like to, but that's not something that we're allowed to do right now. So I wouldn't be able to look in individuals to sort of capture the trajectory along the way. We'll sort of be just capturing that last time point. But I think that's one of the reasons why we really wanted to include infant-related attention and some other measures like that along with what we're doing, because we think that that may be continuous with some of these changes. I'm trying to remember the other questions. Yeah, breastfeeding, non-breastfeeding. Certainly we'll record in this pilot collection. There's no way that we'll be able to properly stratify, but we are certainly going to use that and include that in control analyses at the very least. And there was another question.
No, that's all right.
Okay.
I echo my colleague. Great presentation. Actually, my question is for Tyler, a medical student. You touched on something that is my soapbox for the residents, which is you need to talk about birth control. I have it as like, please, you need to know what birth control. And of course, 6 months after my lecture, I go to the clinic to supervise them. It's like, so this 25-year-old woman, she sexually active, and what kind of birth control method is she on? So it's like, I have no idea. Like, oh God. So given that you're a little bit closer to, coming from medicine and you're still in your training, is there anything, are we finding the same blind spot that we have with the OBGYNs that know that it's okay to use these medications, but 2 months later, they're still not doing it? Where does the blind spot starts? Why are we as psychiatrists do not know what birth control our patients are, or at least be curious about it? And if you can give me any pointers, I would truly appreciate it.
Yeah, that's such an interesting question. I think, and like I had mentioned, I'm from the community hospital, right? So, and there's residents in OB, there's residents in psych everywhere. But what I've seen, because I came in young, hot-headed, thinking, oh, look at all these people. If they want birth control, we can just give it to them, right? But it doesn't work that easy, because I think everybody, OB doctors, medicine doctors, psychiatrists, we all sit inside of this box that is defined as ours. Like, we're in the psychiatry box, right? They're in the OB box. Yeah, exactly. Right. So we can prescribe birth control and they can prescribe antidepressants, but are you going to do that? It depends on your level of comfort, which I think somebody talked about this. Yeah, it was you, right? Yeah. So, improving that would be great if we could get that cross collaborative care, or if we could even work together in consult, like, hey, can you help out on these cases? At least in our community setting, it's kind of controversial. Because there was a QI project that was started that was for women who are inpatient, hospitalized, and interested in getting birth control. We were like, okay, we can give them progesterone injection. But even that, getting the approval was rather controversial, because some of the psychiatry attendings who had been there more seniorly were like, no, we don't want to go there. You're a resident, you're going to prescribe it, but it goes under our liability, and they didn't feel comfortable with that. So I think it just depends on individual comfort. And the other thing too is, even though only a few women did get those injections, at the end of the day, are they following up and getting more injections? Are they going to continue taking oral contraceptives later on too? So I don't know the literature on this, but especially for women with psychotic disorders, which is what I focused on, I feel like the way forward is really with the LARCs, the long-acting reversible contraceptives. and getting psychiatrists to prescribe those is even harder, right? So I think improving cross-collaborative care would be the way forward. But in terms of what I'm seeing in the community setting, it's just not there, right? The women are kind of just falling through the cracks, and it's rather unfortunate.
I'm Nahama Dresner, and I just I'm so proud of each of you who presented, most especially Nancy, who's going to take this thing postal and national. It's going to be amazing. I just had a couple of comments and a question. Tyler, I think one of the things that I think we forget about sometimes in dealing with psychotic patients is that there's profound and known cognitive impairment associated with psychotic illnesses, even with bipolar illness. So aside from whatever assessment you make, of her, does she know what to feed a baby? Does she know what a baby might need when they cry? Having some assessment of cognitive capacity is extremely important and deteriorates over time. And we all know that patients who think their babies might be taken away by DCFS or whoever avoid prenatal care. They come in, they may go someplace or something, and they go to a different hospital to deliver as if nobody will know that they're, have a chronic mental illness. So that's something to kind of,
I guess I just stay up here for a second. So, yeah, absolutely. I think it's such an interesting point that's kind of glanced over. And even in my project, we look at the outcome as, was CPS involved or not? But it's so much more than that, because even mothers who have schizophrenia and their kids have been gone for a long time, you talk to them, a lot of them are still fixated on their kids, right? And it's probably related to these brain changes that are permanent that you had mentioned in your talk, right? There's something that changes and it's a part of their life. And so it's so important that we do what we can to connect that. But in terms of the assessment of the removal or not, or the social determinants of which hospital a patient would choose, unfortunately, from what I've seen in the literature, and it's been a minute since I've caught up on this, but there's a lot of investigation looking at like racial determinants, like certain races are more predisposed to having CPS outcomes rather than their white counterparts. So I think that's a really interesting area of research that is kind of evolving to see if we can standardize that, reduce those biases. And in terms of the cognitive impairment, I think that's a wide open spot for investigation.
Yeah. The other comment I had was for Marissa. And my motto as a CL psychiatrist is, if I do my job right, I won't have a job. And so I think it's funny because sometime in the early 2000s, I did a study that I presented here on bringing OBGYN residents into 6 weeks on the consult service. So every OBGYN resident in Northwestern spent 6 weeks on a psychiatric consultation service, mostly under my, women's health kind of connection. And they'd go and see a patient and they present the patient. And I would say, well, what do you think? And they would say, well, they need a psych consult. And I'd say, well, you're the psych consult. Kind of without any instrument of education, sort of just a clinical exposure to things. And I looked at the same things: comfort level, diagnosing, prescribing, referring, whatever, before, after, and 6 months after. And the rate after the rate was like 30 something, and then up to 60 something. And then it went up into the 70s in 6 months, meaning that experience had gelled in them and led them to maybe experiment more in treating patients, diagnosing patients, and that increased their confidence level. And they, so it is, I wouldn't look at the disappointment. I think in 20 years, we've come a long way, where OBGYN who says you can't be on any medicine, stop all your medicine cold turkey. I hope there's none of them around anymore. And since the ACOG supports the use of psychotropic, blah, blah. So that's been a huge shift because of all the work that, all of us are doing. And bravo.
No, I think it's a great point. And I think that even like with our study, we saw that a little bit, the comfort level is there. And I think that's actually a success in some ways. And maybe that is all the work that's being done and all the education that's being provided to them in some way. It's the question for me, it's like, how can we get them to be more comfortable doing it? But I like the idea of like a full immersement into psychiatry. I think it would be challenging, at least at our institution, to get people fully on board with that. But I love that idea.
The study actually got a prize from ACOT.
Oh,
Which of course the training director at Northwestern got, you know. But it was really, you know, to get over here to stop it was really
that's great.
for them it's like vacation.
Maybe that's how I'll try to sell it. Yeah, at Hopkins. I like that.
Thank you all for the great presentations. Questions for Dr. Byatt. Really exciting to see the results, Nancy. Did you look at difference in outcomes based on severity of depression? So the EPDS scores, I forget the standard deviation, but they were in the range of mild depression. But did you look at what happened to patients who started off with a baseline moderate to severe depression?
It's a good question. We have not done that yet. So no, we have not done that analysis yet. No, I can give a high level summary of a couple of things we have looked at. We looked at this, a PhD student that I mentor, Esther Bayamar-Nerico, looked at it by race and ethnicity. And it was interesting because what Esther found is that she looked at the care pathway by race and ethnicity. And what she found was that when people are treatment, once someone's referred, treatment initiation and sustainment rates were similar among Black, Indigenous, other people of color, as compared to non-Hispanic white women, but the referral rates were lower. So it's interesting because I feel like, as I've seen a lot of times you'll see in the literature that there'll be statements saying that, that people are less likely to initiate treatment or sustain treatment. But what we saw was actually it was a referral. So once they refer, they're actually going the same, if not more, but it was the referral rate. So there's clearly gets back to that reach I was talking about. And we also, I didn't mention this, but we also looked at anxiety. And it was really interesting for anxiety, which I think it gets a little bit to your question, Amrita, because, because if people have another mentee, a postdoc, Martha Zimmerman, she's doing analysis right now. And what she looked at was when people screened positive for both depression and anxiety based on the GAD-7. And what she found was that similarly, like you saw improvement in the EPDS and a similar trend as you do with the depression. But what she found was that at 3 months postpartum, there was a difference between the groups for anxiety. And while we didn't look at it by depression severity, I think when there's comorbid depression and anxiety, it sort of is a different way of looking at how complex the illness is. And at 12 months postpartum, you didn't see that difference. It wasn't different. There was no difference between the groups, but there was a within group difference from baseline to 12 months postpartum. There was a difference between baseline and 3 months postpartum, but at 3 months postpartum, there was a difference between PRISM and MCPAP for moms. So it's interesting because what that sort of potentially indicates is that when people have more complex illness, this proactive, like having the navigator and doing the follow-up and having more help them. But the intervention, because OB care ends at 6 weeks postpartum, typically, right? Like there's that whole, which I know you've written about, Amrita, the postpartum gap. You wrote that a beautiful paper about that. Like, I think part of what we may be seeing is that for anxiety, they were better in the beginning, but that the intervention's not meant to go till a year postpartum because OB care doesn't go till a year postpartum. So not a direct answer to your question, but related data. Yeah, it's a good question.
Hi, I'm Ariadna Ferre from Yale. I have a question for Sarah. So one of the things I didn't see in the list of sort of questions that you got called for was about substance use. So do you have an addiction medicine service, or do you not normally see substance use in your hospital?
It's a I'm like, when that is one of my the fellowship director is Dr. Greenstein, one of the co-authors sitting in the back. We definitely do see but it's interesting because we hardly got called. There were one or two folks that were buried in there, like under the multifactorial. One of them had a distant, many diagnoses. One had a distant history of polysubstance use, and for one person who was who's called for capacity assessment, there was a question of concurrent and recent substance use, although I believe nothing was coming up on the urine. So it's a pretty small. We're talking about 3 cases, so the likelihood is that we're not being involved is my suspicion, just as we're not being involved in probably the other cases where we might potentially be involved. And we don't have an addiction service in the hospital, but it is a growth, sort of point that I think folks are working on between CL psychiatry in partnership with medicine to increase our addiction related care and there's, I think, when I'm between, I just graduated and I'm some, but there's a hope that we can have consultation for addiction on the medicine floors. I think it's an early, an early hope, but it's something that folks are looking at and working on. But I agree. I think it's impossible, right? Just based on what we know on the numbers, there's more people out there and we're just not being involved.
So this is somewhat of sorry for my voice, a loaded question for both Dr. Beal and Dr. Carlini, because what's interesting is working with Sarah, it's evident that one of the things as CL psychiatrists, we want to teach people how to fish rather than just giving them fish. And we're not really doing that on the OB side because we're missing a lot of these. It's not that we're just not getting the consults. So why is that? So then do we use the flip model? Is there a way that we can kind of teach better so we can get appropriate counsel so we can really help the patient long-term, not just to clear them psychiatrically because it's day of discharge?
I mean, I think that's a good point. I think it's a question of sort of how closely tied are you on the inpatient side, right? Because it's kind of two different models a little bit, right? Like the inpatient consult service versus like outpatient OB. The benefit of my role actually is I'm sort of in both of those, but we don't always have, CL psychiatrists who are also perinatal. So I think that's an interesting point. To me, I sort of see the consultation piece as maybe an opening to start that psychoeducation and say like, hey, let's start this person on Zoloft and this is my titration schedule, and then let them like see, right, like what you're doing. But I think other providers might say like, this is a silly consult, like outpatient follow-up. So I think it depends on like your style and like how much you want to engage the OB teams as the consultant in the hospital in that setting. That's my thoughts.
I would just quickly add that I agree. I think it's a matter of style and kind of what you bring. Some folks might ask them if they're having suicidal thoughts now, ask them, kind of all of the acute sort of danger, risk stratification questions and kind of leave it at that. But I think for folks who, that there's an opportunity. And really, I guess as I'm saying it out loud, maybe what that brings to mind is that if we could make it less about an individual's inclination and build, this into something that's integrated into our system, then that's really what we need to be doing versus sort of relying on folks to kind of take the opportunity that's there, which is why I'm so happy to be here and to listen to these wonderful presentations about things that we could do, ways that we could educate our colleagues and again build out a system that's going to treat people versus relying on what we can scramble to do as individual providers.
Hi, everyone. I'm Sibel. I'm in Northern California. Good to see everyone again that I've seen throughout my training. I would love to see a flip guide for inpatient. I think that would be a great project also to be integrated with an EMR outpatient and inpatient. I think would be a really, with Epic, it's pretty easy to incorporate these things like through an order set. And that can be a really nice way to have it easily available. I don't know if that's a possibility in your institution, but that's something that I'm working on in my institution, and that doesn't seem like a huge project. But my question was really for Sarah. I'm gonna go there. I think you expected someone to, but it's really about these consultation, these non-acute consultation. I absolutely value the idea of psychoeducation for every single woman. I think this is part of our mission. And it is also my pet peeve for me to be consulted on someone who has absolutely no acute symptoms going on. I value everyone I consult and I like to expect the same back. So I wonder where that is coming from. Like they are initially, you mentioned, right? They are initially consulted by an OB social work. How come they are not getting, enough of an evaluation or referral or connection to, bridge that gap and be able to move forward without having us involved? Or is it again, going back to the level of comfort? I'm just curious your thoughts about that.
I mean, I think it's a great question. I know that I think Dr. Greenstein and I have talked over this, question kind of endlessly is what is, and there's some dimensions to this to kind of keep in mind too, that we've also brought up. There's perhaps stigma, is something that has come to mind for us. Are we getting called, because for these folks, because there's a sense of, oh, there's something, about this history. I just, we need to kind of, psychiatry needs to come in here and address this. And is there something stigmatizing about stepping into a patient's room when they just told the team that they took Tylenol when they were 15 after they broke up with a boyfriend, and now they have to kind of explain themselves to the psychiatrist? Is that a way, we have to be really mindful, I think, in how we phrase things and how we come in so that we're not accidentally, doing some kind of harm, and how we come in. And so, so I think we should, I think, question, why, we're being called. And also it's a resource question, and again, in a busy day, kind of having to, sometimes it's just, this kind of getting is a little bit, I'm like, it's a little bit of a dodge, but I have to say, this is again why I think that integrated behavioral health for obstetrics is so important, because we can answer, I think, some of these needs in an informed way, and we can also maybe do some of this education as someone who's present, who everyone knows, who's on the floors, who we're not a stranger, we're not coming in from a different, like completely different side of the hospital to lecture people about what they, should be doing, and to kind of grow so that we're growing the capacity of the service itself to do this when we need to be called, having people feel empowered, feel supported, that we're not just saying, no, we're not going to see this person, you're kind of on your own, but saying it's okay, you've got the capability, you've got the resources, and we're here, if you need us. But it's tough, and there's
I mean, back in the old days, when there were like 12 people in the hospital, we had 2 nurses, we didn't have an addictions person. And the kinds of questions where there was a question about history, they're like softer concepts that these folks could see, and if they needed to escalate them up to, and some of the other things we see they could. But there was a system in place for kind of almost assessing the acuity for how much needs to be done here. Obviously, there have to be people who are trained to say hey or nay, but it was, one of them was a nursing gynecologist. We never got a sense. And she was there. And when she talked to everybody, she talked to her. She was there digitally.
right. Right. And I think from a QI perspective for our service, it also, that lack of standardization is, again, speaking to the concept of having individuals kind of making decisions versus having, services or kind of, or policies, I think speaks to that too, because there's some folks who will inevitably call you if someone says that they have a history of suicidal behavior. And there's some folks who are totally comfortable, but again, it's based on, individuals versus plan or service, which is what we want to move towards.
We are just about at time. I'm gonna go ahead and use my power up here to ask the last question. But sort of bringing that back, I wonder, are the scales, are those an opportunity for us to bring that into the conversation? And I wonder if we're getting consults, because everyone's, appropriately concerned about postpartum depression, and this person has depression in their chart. Should I do something? And I wonder if we can use guidance to say, like, well, have you done Edinburgh, and what's that look like? Just like if someone has diabetes or hypertension in the chart, the first thing you do is check their blood sugar or check their blood pressure. And so I wonder if that's something that we could bring into educating our colleagues in terms of, if they have the diagnosis but no symptoms, then let us know if they have symptoms. I just wonder if that's something that.
I think it's a really good question, and I think what you were just getting at is that I think it's a difference being proactive versus reactive. And what we're hearing is like, well, everything that's happening on the consult service, right, and your data, it's totally reactive. It's like for whatever reason, when they call those consults, they're reacting to something, whether that's like they're countertransference, they're countertransference, who knows? But like they're reacting to something. And I think when we were talking about the scales and the education, you know, if we think about like what I presented for PRISM, like we probably need an approach for systematically, like, you know, educating, provide like Nahama, like you said, when they had RNs who met with everybody, but actually make that approach systematic and doing that in a way that's proactive and builds in an infrastructure. It's not like, oh, I like willy-nilly, like I feel like consulting, and they're not like, and then the CL psychiatrist. And when I was doing that inpatient work, I also was like, you want to help everybody, but you can't. And when you get a consult like that, it's just not a good use of resources. It's not a good use of a psychiatrist's time. So that would be my thought, that like it could be used scale, psychoeducation, all of those things. And it's implemented in a way that's systematic and is done proactively versus kind of like, and I think a lot of CL is very reactive. McPap for Moms is reactive, and that helps, but there needs to be other stuff in addition to that to make sure that you're really, you know, because that way you can eventually prevent and use the resources more efficiently. So those are my thoughts.
Well, thank you so much to the speakers and everyone for being so interactive.